Hi, everyone, and welcome to today's Fight Colorectal Cancer webinar. Today we are presenting ASCO 2018 in review. I'm Sharon Worrell. I'm with the Fight Colorectal Cancer team. And before we get started, I just want to thank the rest of our team, including Michael Sola and the communications team, for their help getting this webinar up and underway. And of course, we're thrilled to have Dr. Goldberg here as our presenter. After the webinar, you can view the recording at fightcrc.org/webinars. And also after the webinar, you will get an email with links to the materials and also to a quick survey. If you fill that out, we will send you an iHeart Booty bracelet. During the webinar, you can ask a question using the panel on the right side of your screen. And finally, follow along with us on Twitter using the hashtag CRCwebinar. Here's just a little slide of the screen on your right side. If you have a question during the webinar, feel free to type it into the question box, and we will address those in the Q&A session following the presentation. Fight Colorectal Cancer has a comprehensive library of resources for patients, survivors, and others touched by colorectal cancer. Your Guide in the Fight was recently updated in early 2017, and is a detailed resource discussing everything from dealing with a diagnosis to treatment decision-making and more for late-stage colorectal cancer patients. So just want to make a quick note that the information and services provided by Fight CRC are for general informational purposes only, and are not intended to be a substitute for professional medical advice, diagnoses, or treatment. If you are ill or think you may be ill, please see a doctor immediately, and in an emergency, call 911 or go to the nearest emergency room. And finally, we are so thrilled to have Dr. Goldberg with us today. He is West Virginia University Cancer Institute's director and director of the WVU Cancer Signature Program. He's also one of Fight CRC's medical advisory board members. Thank you so much, Dr. Goldberg, for joining us today.
My pleasure.
I will go ahead and hand over the controls to you, and we can dive into our session.
Thanks very much. So just to give you a flavor of what the ASCO meeting is like, it's a convention of about 35,000 people, oncologists from all over the world in all disciplines, as well as representatives from pharmaceutical companies and advocacy groups, including Fight Colorectal Cancer. And it's our biggest meeting of the year. Everybody in the world who's anybody comes to hear the latest updates and to present their research. And careers are made by excellent presentations at ASCO. So it's quite a heady atmosphere. Now, each of the abstracts that are chosen from among thousands for presentation. And I'm only going to present about 10 of the abstracts, which I thought would be most interesting to you. So this is going to focus just on colon and rectal cancer. And I'm actually going to start with rectal cancer. And to put rectal cancer into context, there are two important issues in talking about rectal cancer. One is that the rectum, unlike the rest of the colon, is tethered in place. So it becomes a place that radiation can be directed to because it's not moving around like the rest of the colon. And also the rectum has one less layer to contain cancer because what we call the serosa, or an envelope around the rest of the colon, is not present around the rectum. So there are more rectal local recurrences in rectal cancer than there are in colon cancer. And so when we talk about recurrent disease in rectal cancer, we talk about local recurrence. That means in the area of the rectum where the tumor started, or distant recurrence. And of course, both of them are bad, but they are addressed by different treatments. And so
Dr.
what
Goldberg,
are our...
I'm sorry to interrupt. Were you able to pull up your slides?
So they're visible on my... Oh, hang on. Does that pull them up?
There they are. Thank you.
Okay. So I'm on the second slide, which is now talking about strategies to reduce the odds of recurrence. We have three ways we treat rectal cancer: surgery, radiation, and chemotherapy. And we're now beginning to ask the question, does everybody need all of that? Or are there selected people who could get away without surgery or without radiation or with less chemotherapy? And how do we best integrate these three techniques? So let's first focus on surgery. So surgery for rectal cancer can be done as an open operation where you get about a 9-inch incision starting just above the pelvic bone and continuing up to about the area of the navel. Or it can be done robotically or using laparoscopy, which results in several small stab wounds in one 2-inch incision. And many surgeons are actually preferring to do robotic or laparoscopic surgery because the recovery is quicker and the invasiveness is less. Now, as you might imagine, the skill of the surgeon matters. And how do you judge if you're a consumer of surgical services? So one way to judge is, does your surgeon work with others hand in glove, and they need to? Has your surgeon been trained in colorectal surgery? Do they do a high number of cases per year? Are they distinguished by having endorsements by best doctors or other endorsing groups? And do other specialists recommend them? And one of the things to be cautious about that is that we recommend our friends to each other. And you want to be recommending someone who's both a friend and an excellent physician. Now, what are the goals of surgery? Well, it's to take all of the cancer out. And we call that a complete total mesorectal resection. And what that means in English is you take out the rectum and you take out an envelope of fat and lymph nodes surrounding the rectum so that it looks very much like a sausage when you take it out. And that's the best way to include all the potential tumor cells as they're trying to spread to other parts of the body. In order to be confident that we've gotten a good sample, we need at least 12 lymph nodes. And a good surgeon is spending everything he has or she has in her ability to preserve the patient's ability to have bowel movements through the anus when they're done with the surgery, if that's possible. And in some cases it is, in some cases it isn't, and it often depends on the skill of the surgeon. Now, this meeting, ASCO, is mainly not a surgical meeting, and there was nothing new in surgery presented at this meeting. Now, what about radiation? Well, radiation is also a team sport, and you need other members of the team, including surgeons and medical oncologists. Like surgery, radiation is a skill that is dependent on the doctor, not just the radiation oncologist, but also the physicist, who's also usually a PhD working with them, who designs the radiation fields. And radiation is a technical specialty, so the quality of the machine that you're treated on matters. And there's a new technique called intensity modulated radiation, or IMRT, that requires a higher technical ability and a newer machine in order to try and spare healthy tissue around the rectum as much as possible. And recently, we've gone to giving radiation before surgery for several reasons. And one reason is it can cause complete disappearance of the primary tumor, which may permit less surgery. And also, if you radiate bowel, it becomes stiff and non-compliant, often causing people to have accidents or frequent bowel movements or clustering of bowel movements. And if you take out that radiated tissue at surgery, then you remove that compromised bowel. And then medical therapy means chemotherapy or targeted therapies. And again, medical oncologists need to work with the other two disciplines and do multidisciplinary consultation. Our standard treatment now is a long-lasting drug that was discovered in the 1950s, 5-FU, or its newer oral cousin capecitabine, which are used to sensitize cancer cells to radiation, making the radiation more likely to be lethal to them. And questions that we're asking now are, can we add extra drugs that'll make the treatment outcome better? In prior years, we'd had data with the angiogenesis inhibitor bevacizumab or Avastin and with cetuximab, and neither of them added to the efficacy of 5-FU with radiation. And a lot of questions were asked at this meeting about oxaliplatin. We'll get to those in a minute. And so one of the other big questions in rectal cancer is, does postoperative chemotherapy after radiation and 5-FU, followed by surgery, help? So now let's talk about 3 studies that are new from ASCO. and medical oncologists and other cancer docs like to give their studies acronyms. So we're going to present FORWARK, HETAC, and ADORE. I don't want to hear your criticism of our ability to choose acronyms, which aren't perfectly representative of what we're doing. So the first study I'm going to talk to you about was submitted by a group of Chinese colorectal surgeons, and it had 3 different treatment arms in it. So here are the 3 treatment arms. The top arm here is what's called the degramant regimen, which is just 5-FU with the vitamin that makes 5-FU work better called leucovorin. And initially, that's given with radiation. TME means total mesorectal excision, and that's the surgery. And after the surgery, patients got the same chemo. In arm 2, patients got the addition of oxaliplatin to their chemo. They got radiation first, surgery, then chemo alone afterwards. And in the third arm of the study, they got the 2-drug chemotherapy, FOLFOX, surgery, but no radiation. And this is a graph that shows what's called the pathological complete response. So after the chemo and radiation, when the surgeon went in and operated and the pathologist looked at the surgical specimen, a pathologic complete remission meant that the pathologist could find no cancer cells. And that's good news because that often translates into long-term cure. So you can see that with FOLFOX plus RT, that there was a 30% likelihood that the pathologist would find nothing. With FOLFOX alone, it was 6.9%, and with radiation plus 5-FU, it was 13%. So that is the positive finding in this study. The next thing we looked at was local recurrence rate. And the good news here is that those bars all top out at a 10% likelihood of local recurrence. And that's much better than we used to do, and as a combination of the consequences of better surgery and better treatments. But you can see here that there's no significant difference whether the patient got 5-FU with RT, FOLFOX with RT, or no radiation at all. And so that's an important finding in this study. Also, you can see the disease-free survival. So that means how long it took for the cancer to come back, and the patients who came back in was no different, and that about 65% of people never had the cancer come back, and that the overall survivals were all about the same at about 80%. So what did we learn from this study? Well, we learned that there was a higher pathologic complete regression rate when you use FOLFOX plus RT. But there were no differences in the disease-free or overall survival. Now, the trouble with this study is it was a 3-arm study with only about 165 patients per arm, and therefore it's not a definitive study, but it suggests to us the possibility that not every patient needs radiation, and I'll come back to that later. So what about the next study? This is a study that was done worldwide, but chaired by our colleagues in Germany. Presented by Dr. Schmoll. And this study looked at radiation before surgery in all patients. Half the patients got just capecitabine, which is a pill form of 5-FU, and half got capecitabine plus oxaliplatin. All had surgery, and patients who got 1 drug preoperatively got 1 drug postoperatively, and patients who got Capox, the 2-drug regimen, preoperatively got 2 drugs postoperatively. So the question in this is, does Capox add to capecitabine when combined with chemotherapy and radiation? And here again, you can see that the local recurrence rate was under 10%, but no difference between the 2 arms. And that the distant relapse rate was about 25%, but no difference between the 2 arms. And then the overall survival rate was the same at 7 years, which is a long time, and the patients that make it out to 7 years and haven't had a relapse almost never have a relapse after that. So that represents about 65% of patients being cured, which is good news. Here you see the overall survival, no difference among the patients. So what did we learn from this study? Well, between the two strategies, there were no differences in local recurrence rate, distance recurrence rate, disease-free survival, or overall survival. So my conclusion from the study is that oxaliplatin did not add value compared to capecitabine alone, and it does add side effects. And so it is very reasonable, based on this very large study of 600 patients per arm, to consider just using capecitabine without oxaliplatin. Now, what about the ADORE study? This was presented by a group of Korean investigators. And in this study, all patients got chemotherapy with 5-FU or capecitabine. They all had surgery. And after surgery, those who still had residual disease, which is what is meant by YP stage 2 or YP stage 3, were randomized to get just single agent 5-FU or FOLFOX. And here you can see that initially it looked like the disease-free survival was different, favoring treatment with FOLFOX, because more patients in the yellow line on this graph were disease-free than those in the green line, which was just the 5-FU. But one of the questions is, does FOLFOX eliminate disease or just delay its recurrence? And the answer to that, according to this slide, is that there was no difference in overall survival. So the patients who initially had a longer disease-free survival rate because of FOLFOX, that didn't translate into an overall survival advantage. The good news in this study is, if you look down at the 6-year overall survival rate, it was between 76 and 78%. And these patients are a higher risk group of patients because they did not have pathologic complete remissions from the chemotherapy and radiation at the time of surgery. So this is showing very good outcomes. So what did we learn from this? Well, that an initial disease-free survival advantage favoring FOLFOX didn't translate into an overall survival advantage. And so when you come away from this, what is the standard of care in rectal cancer? Well, it's multidisciplinary teamwork between your 3 specialty groups. It's preoperative chemotherapy with 5-FU or capecitabine. It's radiation by an excellent radiation oncologist working with an excellent physicist on a modern machine. It's a total mesorectal excision done robotically, laparoscopically, or open by an excellent colorectal surgeon. And then it's postoperative chemotherapy. And school is still out as to whether 5-FU by itself or capecitabine by itself or FOLFOX or CAPOX are the best treatments. In the US, we tend to combine oxaliplatin with either capecitabine or 5-FU in this setting, but we need more information on that. Now, there's a large study being done in the US by the cooperative groups known as CALGB 8101, led by a group of docs from around the United States. And what this study is looking at is giving chemotherapy first. Not chemotherapy with radiation, but chemotherapy first. And then doing a complete restaging. And if patients have no progression of disease, they go directly to surgery. If they've had progression of disease, then they get radiation with 5-FU. And after that treatment, if they have a complete resection and they had not previously gotten radiation, they will be randomized to get radiation or to just get chemotherapy. And the reason for this is that radiation has long-term side effects, particularly in young women of childbearing age, where it often makes them infertile. And we would like to be able to eliminate that treatment. Now, more than 1,000 patients have been enrolled in this study, but we still have another 100 to enroll, and then we'll have to wait for this study to mature. So the bottom line is, in rectal cancer, we're trying to refine our treatment by figuring out who needs all 3 methods of treatment and who can get away with less than that and still have a good cure rate. Now, the next thing I want to talk about is what we call prognostic and predictive markers. So we're asking the question here, how can we tell who will benefit from chemotherapy after surgery? And prognostic markers are markers that tell us who will do well and who will relapse. And an example of that is staging. So we do what's called TNM staging, We look at the tumor, how deeply it's invaded, how it looks under the microscope, whether it's gone to lymph nodes, and whether it's metastasized. And tumors that have metastasized do poorly. People with those tumors do poorly. And so staging is a well-accepted prognostic marker. Now, predictive markers will tell you who will benefit from a given therapy. And an example of that is that we know that patients who have tumors that have RAS mutations have resistance to two of our targeted agents, cetuximab and panitumumab. We don't use those agents in patients whose tumors have that mutation. So what we're going to talk about today is actually circulating tumor DNA as a predictive or prognostic marker in patients with colon cancer. And this was a small study done by the Johns Hopkins group, which has been a leading group in colorectal cancer treatment, looking at what we call circulating tumor DNA. These tests were done in 95 patients. They had repeated testing done. And the background of this is that in colon cancer, about 50% of patients with stage 3 disease, that means lymph node positive disease, are cured just by surgery. We wish we knew who those patients were so we wouldn't give them chemotherapy. Chemotherapy cures an additional 25% of patients, and we wish we knew which patients those were so those would be the only ones we'd give chemotherapy to. The remaining half of the patients who are destined to have relapse despite chemotherapy. And currently, we have no way to determine accurately who will recur and who will benefit from chemotherapy. Now, this is a cartoon of a blood vessel with things inside the blood vessel. And in the blood vessel, you see the star-shaped tumor cells that are circulating. And then you see these little squiggles, which are the double helixes representing DNA. And this study looked at circulating DNA. So when tumor cells break up in the blood vessels, their DNA is left, and we can capture that by doing a blood draw on them. Circulating tumor DNA tells us when there are abnormal cancer cells present in the bloodstream, and its presence is predictive of recurrence. And so this study was a feasibility study to look at whether or not this would be helpful. So the objective was to see if finding circulating DNA or not finding circulating DNA would predict recurrence and benefit from chemotherapy in 95 patients who were treated with adjuvant chemotherapy. Now here you see in 19 patients, after operation, their first blood test showed that they still had circulating tumor DNA in their blood vessels. And if they did, their 2-year relapse-free survival was less than 50%. Now, our assumption is that chemotherapy can get rid of circulating tumor cells that are left over after surgery half the time. And that was really pretty well confirmed in this study, because if patients had positive DNA after surgery and were treated with chemotherapy, only a third of them relapsed. If they had positive DNA even after adjuvant chemotherapy, they only 33% of them did not relapse. And if they had positive DNA but were treated with chemotherapy and that DNA disappeared, 60% of them were cured. Now, what about the patients who had an initial postoperative study with no circulating tumor DNA? Well, 84% of those patients still had no relapse after 2 years. If the test became positive, then 25% of them were free of relapse at 2 years, but if it remained negative, 86% were. So this was really a validation study which suggested that this could be useful. And we actually are already developing a study to look at this in patients who have stage 2 colon cancer. The standard of care for those patients with node-negative cancers is no chemotherapy. What this study is looking at is if we find positive circulating tumor cells in those patients, we're going to randomly assign them. We're going to treat all the positive patients with chemotherapy and observe the negative patients and see how they do. So the summary here is that it was feasible to do this. It did have prognostic implications, and it has the potential to be useful in the future. So now I want to turn to talking about metastatic disease, and I'm going to talk about 4 different areas. One is the subset of patients who have peritoneal-only disease, and I'll describe that more in a minute. Then we're going to talk about initial chemotherapy for advanced disease. We're going to talk about the subset of patients who have what's called microsatellite high colorectal cancers, and then talk about later lines of therapy. So the first study we're going to talk about is called the Prodigy 7 study, and it looks at patients who have what is called peritoneal tumors. That is, tumors that have spread in the lining of the abdominal cavity. And in this case, you can see in a prior study that those patients have a worse prognosis than other patients with metastatic disease. So if you look at the little red box there, 16.3 is the median overall survival of patients with peritoneal disease as compared to longer median survivals of 25 months and 19 months for lung-only or liver-only disease. This was a bit of an older study, and the bottom line is that peritoneal disease is a poor prognostic marker for colorectal cancer. Now, there have been some prior studies looking at what we call cytoreductive surgery. That's when the surgeon goes in and removes all of the cancer they can see. That's what CRS stands for here. Followed by what's called HIPEC, which is hyperthermic or heated intraperitoneal chemotherapy. And there have been some old studies about this, mainly retrospective studies, that have shown that in patients with only peritoneal disease who were managed this way, the median survivals were better than the 16 months we saw, about double that. And in the one study, which the graph shows on the right side, that was a prospective study, patients who got heated intraperitoneal chemotherapy as opposed to just surgery alone did better. So this particular study took patients with peritoneal cancer of colorectal origin and no disease besides that, and randomly assigned them to chemotherapy or no chemotherapy after cytoreductive surgery. They all had to have colon cancer. They could not have disease outside of the peritoneal cavity. They had to have a limited amount of colorectal cancer in the peritoneal cavity, which is what this peritoneal cancer index refers to. And they had to have no gross residual disease after chemotherapy, after surgery. All the patients were to get chemotherapy, but only half of them got the intraperitoneal chemotherapy. Now, the one oddity about this study is that they mainly used oxaliplatin in the heated intraperitoneal treatment. That is, they put the drug into fluid and put it in the abdomen after the operation. They gave intravenous 5-FU, but oxaliplatin has no activity by itself, and 5-FU only has a half-life of about 15 minutes. So they gave the 5-FU and it was gone quickly, and it's not clear that it was an optimal way of managing these patients. You can see here in the ITT block in the middle that there were 133 patients who got the HIPEC and 132 patients who did not. And here you can see the overall survival was the same regardless of whether you got the chemotherapy. But the good news in this is that the median overall survival for this group of patients was over 40 months. And at 5 years, about 40% of patients were still alive. And that's certainly a much better survival rate than we're used to in this subset of patients, suggesting that even if the HIPEC didn't matter, better treatment and the use of the cytoreductive surgery contributed to the longer survival of these patients. Here you see the relapse-free survival. Now, there was one subset of patients, those with the least amount of disease, that seemed to do a little better with the HIPEC, but that's not a standard of care. So what did we learn? We learned that the addition of oxaliplatin did not improve the outcomes over HIPEC alone. but the outcomes with cytoreductive surgery are good compared to historical studies. The hardest part of this is who to operate on with this technique, and that's an art as well as a science. So let's go on to first-line treatment. And the FIRE3 study is a study that actually was conducted in Germany and had been previously reported. It was a study that randomized patients to chemotherapy using irinotecan plus 5-FU, so-called FOLFIRI, and either a targeted drug that targets the epidermal growth factor receptor present on about 60% of colon cancers with the drug cetuximab, or use the anti-angiogenesis drug called bevacizumab. And the outcome of this study was interesting in that the progression-free survival, which is the graph on the left, showed no difference between the two strategies. But the overall survival for the patients who received cetuximab rather than bevacizumab was better. And we now have some insight into that, and that patients who have left-sided colon cancers, that is, tumors that originate in the left side of the colon, and who do not have RAS mutations in their tumors, seem to do better with cetuximab than they do with bevacizumab. And the standard of care on that is changing. And if you look at the bottom of this, the overall response rates were very high in the cetuximab arm at 77% compared to the bevacizumab arm, which is a very good finding. So panitumumab is the other drug like cetuximab that targets the epidermal growth factor receptor. In this study done by the German group, they actually used all three chemo drugs together, 5-FU, oxaliplatin, and irinotecan, so-called FOLFOXIRI. It was a relatively small study. 63 patients got panitumumab with their three-drug chemotherapy, and 33 got just the chemotherapy regimen. But you can see here that they had an incredibly high response rate when they got the panitumumab of almost 90%, which is very promising and really unheard of in this setting, suggesting that bigger studies with this strategy are warranted. So what did we learn for RAS wild-type left-sided tumors? The addition of an EGFR-targeted monoclonal antibody, either cetuximab or panitumumab, is important. So now I want to talk a little bit about immunotherapy, the so-called PD-1 inhibitors for a subset of colorectal cancers, what we call microsatellite instability high colorectal cancers. Now, what does MSI high mean? Well, microsatellite instability reflects the fact that some tumors have what we call deficient mismatch repair. Now, a mismatch in DNA repair is very similar to a mistake you'd make in a word processing program. Mismatch repair is very similar to spell check. It automatically corrects those mismatches. And this occurs when DNA replicates, it unwinds, and then a daughter DNA molecule is made. And the old DNA and the new DNA reattach, but sometimes there are mistakes in that reattachment. And tumors can either develop mismatch repair, or in some cases, people inherit a defective mismatch repair gene. Those patients have what we call Lynch syndrome. So it's either inherited or acquired, but the effect is the same. In those patients, there are many, many abnormal genes that are present or mutations that are present. Here you can see that in sporadic adult tumors, there are only less than 50. But in these mismatch repair tumors that have the deficiency, there are more than 1,500 of these. And these abnormal DNA molecules code for abnormal proteins, which can then become targets of the immune system. And so that's what the PD-1 inhibitors do. And there were 3 studies that were presented at ASCO that were important. The first with nivolumab, which is a PD-1 inhibitor, was given as a single agent. And here you can see that the patients that were treated in this were not a large group of patients. There were a total of 74, but they were heavily pre-treated. So they had more than 3 lines of prior treatment in most cases, meaning that their tumors were quite refractory to standard therapy. And here you can see that the response rate for this group of patients with the deficient mismatch repair in their tumors, which is only about 4% of colorectal cancer patients, was very high, a 25% or a 34% response rate. 25 of the 74 patients responded. And the other oddity about this was about 10% of patients had complete responses, which you almost never see in this setting. And in this setting, you would expect about a 2-month median duration of stable disease, and we saw about an 8.3 month duration of stable disease. So this was quite striking. And here you see each patient who responded represented by a single bar graph. And those patients whose tumors are represented by the bars that go below this dotted line had what we call either a complete or a partial response. And so almost all patients benefited, and many of them benefited with complete responses. And these responses were also long-lasting. So on the bottom line here, we have weeks, and many of these patients were out to 2.5 years still responding, which is amazing. You can see that those patients who didn't progress often had extremely long-lasting responses and never relapsed, and that's also unheard of in this setting. So that their overall survival out here at 3 years was almost 60%, and that's startling. So nivolumab clearly had a durable clinical benefit here with very high progression-free and overall survival rates and a high complete remission rate, suggesting that this is a very good strategy for this type of patients. Now, this group of patients also added a second immunotherapy drug, ipilimumab, which is a CT4 inhibitor, to the PD-1 inhibitor in an attempt to further aggravate the immune system to recognize cancer cells. And so here it was 2 drugs rather than 1, as compared to the 1 drug in the other arm of the study. And when you used 2 drugs, you got a much higher overall response rate. Here you can see it's 51% as opposed to the 31% in the single arm of the study. And over 80% of patients had either tumor shrinkage or tumor stabilization using the 2 drugs. And here you see that similar, what we call swimmer's plot, with 1 patient per lane, showing a high level of partial responses and complete responses, even higher than in the prior study. And again, long-standing freedom from progression and long overall survival, which is now, this does come at the cost of additional side effects, but these side effects are generally tolerable and go away when you stop the drug. Now, there is another drug out there that has been approved for this indication called pembrolizumab. Similar drug, similar outcomes. Here again, you see the swimmer's plot with many of the patients having long-lasting partial or complete remissions. And a lot of shrinkage in their tumors with a progression-free survival that has a long, flat tail on it and an overall survival exceeding 60%. So what did we learn from these 3 studies? That in MSI-high metastatic colorectal cancer, these PD-1 inhibitors can really help people. That putting 2 together helps more than using 1. And my conclusion from this is that all patients with colorectal cancer should have MSI testing for 2 reasons. 1, to determine if they have Lynch syndrome, because that would mean that their relatives would be at risk for colon cancer and need early screening. And 2 is to see if they're a candidate for a PD-1 inhibitor if they have metastatic disease. And one could actually argue that all patients with metastatic cancer ought to have MSI testing, but I'm not going to go into that at the moment. Now, we have some studies that are looking at these drugs in earlier stages. The Keynote 177 study is looking at it as first line, where patients are being randomized to chemotherapy versus the immunotherapy drug. And then there's another study looking at chemotherapy plus an anti-angiogenic agent, another PD-1 inhibitor, atezolizumab, or the chemo plus anti-angiogenesis agent plus the PD-1 inhibitor. And those studies are ongoing. And then there's actually an adjuvant study in this group of patients adding atezolizumab to standard chemotherapy. It only has about 70 patients and needs about 800 patients, so that study is just beginning. What about late-line therapy for advanced disease? Well, the reverse study looked at two drugs, regorafenib and cetuximab. So regorafenib is a drug that targets multiple targets on advanced cancers. It's a pill. Cetuximab, as I mentioned, targets the epidermal growth factor receptor and is more effective when given with irinotecan. And in this study, the experimental question was, is it better to give regorafenib followed by cetuximab or cetuximab followed by regorafenib? And the answer on this study was that it looks like the regorafenib first was the winner. And on this graph, you can see that for the patients who got regorafenib first, their overall survival was 17 months. For the patients who got cetuximab first, their overall survival was 11.6 months. And this is also a very long survival time for this group of patients. So this looks promising as a strategy. Now, another question that we've been asking is, once a patient's tumor develops resistance to an anti-EGFR targeted agent like panitumumab or cetuximab, is it ever worthwhile to re-challenge patients with that? And so what this study did was look at patients whose tumors initially were RAS wild type, who were treated with cetuximab, and then their tumors evolved to develop a RAS mutation and the tumor became insensitive. But then that cetuximab was taken away. And the question was, did that RAS mutation become less of an advantage to the tumor, and therefore did the tumor lose it? And the bottom line was that there were patients who were re-challenged with cetuximab after a holiday from that drug, whose tumors lost their RAS mutation and they became sensitive to cetuximab again, suggesting re-challenge can be useful. So EGFR inhibitor resistance as measured by RAS mutation can change with exposure or withdrawal of the drug, and re-challenge is reasonable. And the second conclusion from the prior study is that regorafenib plus cetuximab seems to be advantageous over the reverse sequence. So the last study I'm going to talk about is this one using ramucirumab. It's a drug that's in the same class as bevacizumab, an anti-angiogenesis agent. In this case, it was a randomized study giving irinotecan plus cetuximab, or those two drugs plus ramucirumab. The bottom line was that there's a better partial response rate with 3 drugs over 2 and a longer duration of progression-free survival. Here you can see somewhat of a difference between the ramucirumab curve, which is in red, over the curve for the 2-drug regimen. So the overall survival was a bit better. So we learned that irinotecan with both an anti-angiogenesis and an anti-EGFR targeted agent deserves further study. So the bottom line, and I want to leave 15 minutes for questions, is that for rectal cancer, preoperative chemoradiation therapy followed by adjuvant therapy remains the same. And that is that all 3 of those modalities need to be given. But we're trying to refine that and see if we can give less therapy over time. The news on the cytoreductive surgery is good in that it appears to be a useful means of prolonging survival and even inducing long-term remission in some patients, even though the oxaliplatin strategy for HIPEC was not useful in this study. The roles of EGFR-targeted monoclonal antibodies need to be refined, but these agents are showing more and more promise with time. And both regorafenib and ramucirumab, two newer drugs in colorectal cancer, have activity in advanced disease. Now, it's clear that we're making advances in colorectal cancer. When I compare the outcomes now to the outcomes when I started my medical oncology fellowship in the early 1980s, we've come a long way. We still have miles to go before we sleep. There are still patients dying of this disease and suffering from this disease. And there's much more that we can do to help them. But the good news is the pace of progress is accelerating. So with that, I'm going to close my formal presentation, and it's time for questions.
Thank you so much, Dr. Goldberg. What a great presentation, and we really appreciate you taking the time to walk us through some of these abstracts from ASCO this year. Just going to pull up my slides here. So we do have a couple questions that came up during your presentation. Let's see, we'll go ahead and begin here. Lately, there's been discussion that liquid biopsies may not be ready for prime time yet. How can ctDNA assays be incorporated into clinical practice, and are they ready to be used?
So I would agree with the statement that these are one of the most interesting techniques that we have, but that they're not ready for prime time. So there are two kinds of assays that we're doing. One is looking at circulating tumor cells, those star-shaped things that I showed you in the cartoon. And then the other is looking at circulating DNA. And, you know, this study by Hopkins is the largest study out there in colorectal cancer, 94 patients. It looks very promising. It looks promising enough that we're going to study this in patients with stage 2 cancer, treating patients who have circulating tumor DNA and not treating patients who don't. But we really don't know how to use this tool yet. I'm confident that the next 5 years at ASCO, we're going to have many presentations about this. Now, if I had colorectal cancer, stage 3, would I want to push my doctor to do a test for circulating tumor DNA? I don't think I would at this point, because I'm not sure I'd know what to do with it. And I understand that people are clamoring for more information in this setting, and we're just as impatient as you are. But we need to know how to use our tools, because using them wrong is dangerous.
And as a follow-up question, is ctDNA, are there any studies, or do you imagine it's appropriate for stage 4 colorectal cancer, as the discussion was only mentioned for stage 3?
Well, so there really haven't been good studies in that, in colorectal cancer. There have been some studies in other diseases that show that when the levels of circulating tumor cells or circulating DNA go down, that's a good marker that a chemotherapy program is working. And that when they start to go back up, that's another marker that chemotherapy isn't working. Having said that, there are other ways that we can tell that, principally imaging studies, as well as by looking at CEA in those patients whose tumors make CEA. So again, it's a tool that we're developing, but don't quite know how to best use yet. And in this case, we certainly have other tools that we can use that we know how to apply.
Thank you. We'll move to the next question. Were there any studies presented on immunotherapies for MSS colorectal cancer?
Well, so there is a tremendous interest in that. And what I would say is that the data that's being presented is all preliminary. You know, I get a lot of questions from patients about, should I try, I have MSS colon cancer, should I try enrollment in an immunotherapy trial despite the fact that I don't have MSI high disease? And my answer to that is that in most circumstances these days in managing colorectal cancer, patients have a long window of therapeutic options. And often the best time to consider trying a trial like this is when you've had some initial treatment with advanced disease. It's clear that you're not going to be a candidate for potentially curative resection. The goal is to try to live with the disease as long as possible and potentially to bet on long shots like the PD-1 inhibitors turned out to be for those patients with Lynch syndrome-related cancers. And so I advise people to be open to trying clinical trials with combinations of immunotherapy agents. There was nothing presented that was definitive, although there were many posters on studies in progress using combinations of agents. Now, there was the interesting study done by Genentech of atezolizumab plus cobimetinib, which looked at a PD-1 inhibitor plus another immune stimulating agent. And even though the phase 2 study looked promising, the phase 3 study was negative there. So you have to be careful about early trial signals translating into real benefit when they're rigorously tested.
So Dr. Goldberg, a follow-up question that just came through. Are any of these findings definitive enough to change your treatment plans for patients with metastatic colorectal cancer?
Well, so the question about whether to use cetuximab or panitumumab with chemotherapy in first-line therapy of metastatic disease has been one we've been debating for several years. And when Alan Vanook 2 years ago at ASCO presented the data from 80405, which was the American study of chemotherapy plus bevacizumab versus chemotherapy plus cetuximab, he didn't conclude the first-line therapy with an EGFR inhibitor was preferred. I believe with the maturing data from the two studies I presented to you, the panitumumab study and the FIRE3 results, the patients with left-sided colon cancers and no RAS mutations in their tumors ought to get cetuximab or panitumumab first line, unless there's a contraindication to that. So I think that that is a change in practice that it's time to implement. I've always wrestled with the role of cytoreductive surgery, and I think now that the data is showing in selected patients who don't have high bulk of disease and don't have rapidly progressive tumors, that it is an effective additional option for treatment. Now, it's a big operation, a long operation, and it ought to be done by somebody who's skilled at doing it. There are centers around the U.S. that specialize in doing cytoreductive surgery and are high volume centers, and those are the places I would go if I was considering this. It also takes a skilled surgeon to say, no, I'm not going to do this because I don't think it's going to help an individual patient. That surgical judgment is both an art and a science. With respect to the use of regorafenib, I have to admit that I had been a person that tended to use regorafenib after other options, and I think that the data from that study that I presented of regorafenib first versus regorafenib second suggests that perhaps regorafenib deserves earlier consideration. However, the initial dose and the dose that's in the product insert for regorafenib has now been shown to be too high. And I tend to start people on a reduced dose of regorafenib and increase it if they tolerate it. So those to me were the practice-changing things in colorectal cancer. I would say as ASCOs go, and I've been to 35 or 36 of them this year, this was not a particularly fertile year for practice-changing studies at ASCO.
Okay, thank you. Our next question, because advocates are often asked about what types of surgery might be recommended, can you give us a general guideline as to the percentage today of open versus robotic versus laparoscopic in colorectal cancer surgeries?
So I can't give you actual percentages, but what I would say is that more and more surgeries are being done laparoscopically or robotically. It turns out that those techniques take training. A robotic surgeon sits at a console like your kid at a video game console and manages the operation with a mouse. And so it's way different than what surgeons of my generation were trained in, which took a scalpel. And the surgeons that trained in the middle between those two extremes learned laparoscopic surgery before they learned robotic surgery. So you have to know that what your surgeon does, he or she is skillful at doing. But if I were diagnosed with rectal cancer, I would be looking for a surgeon who does either laparoscopic or robotic surgery because of the reduced recovery time, the equivalent surgical outcomes, and the lower potential for morbidity for long-term side effects. So I do think that there is value in seeking out surgical centers of excellence for rectal cancer surgery. In many countries in the world, like in Holland, only a limited number of hospitals do rectal cancer surgery, and other surgeons are required to refer patients into high-volume centers.
Thank you. I think we have time for maybe one more question. Let's see. So based on the treatment shift that you've mentioned, biomarker testing is more critical than ever. How do we get the message out there for patients to make sure they are tested?
Well, so I'm guessing that this refers actually to molecular genetic testing. And so molecular genetic testing is important for a number of reasons. First of all, we want to know if a patient has an MSI high tumor, because if they do, they might have Lynch syndrome and their family members might have it. Then they also are candidates for immune therapy. Two is we want to know if tumors have RAS mutations, because that eliminates a class of drugs, the anti-EGFR targeted monoclonal antibodies, cetuximab and panitumumab, if there is a RAS mutation. If they don't have a RAS mutation and they have a left-sided tumor, then I'm telling you that they ought to either get cetuximab or panitumumab with chemotherapy. So it's important there. And then there are the identification of unusual tumor mutations for which we now have highly effective targeted agents. And one of those is TRK mutation. There was just a New England Journal article. There's a drug that specifically targets tumors that are driven by that mutation with extremely high response rates. It's only about 3% of people with colorectal cancer, but we want to know who they are. And so early genomic testing is becoming more and more important for people with metastatic disease. And when I get on the podium, I pound the podium about that. If you go to a large center, particularly an academic center, the docs there know how to interpret it. In smaller centers with docs that were trained a longer time ago, the skill set for interpreting the results of these is spotty. And so to some degree, the patient, I think, has to be an advocate for this. I'm certainly advocating it to our medical community.
Great. Thank you so much, Dr. Goldberg. I think that's all the time we have left for questions. Of course, thank you to everyone who was able to join us today, to the FIGHT CRC team, and especially Dr. Goldberg, thank you for taking the time to run through these slides with us this afternoon.
I hope they were helpful.
Thank you.